Welcome, viewers. Welcome you once again to the brand new episode of JIC's Face Off, the Clash of Opinions. In this exciting round of debate on some of the contentious topics of critical care, tonight our subject is, in the opinion of the House, in real-time evidences, in real time, the sepsis bundles are unrealistic and they only satisfy tick box medicine. We have our esteemed speakers for as both the members of the Treasury and opposition. In the members of the Treasury bench, we have Dr. Prakash Shastri, Chairman, Critical Care Medicine, Sir Gangaram Hospital. Welcome you, sir. In this debate, we are waiting to hear some fireworks from you post Diwali. And we also have Dr. Amrita Bhattacharya, who is also a senior consultant of critical care medicine. Welcome you, Amrita, from Kolkata. And also we have, as members of opposition, Dr. Supradeep Ghosh, who is again the director of critical care in Yatharth Hospital, Noida. Welcome, Dr. Ghosh. Waiting to hear from you as the leader of the opposition, and we'll be supporting him will be a senior consultant from Chennai, Dr. Kalavati Moses. And as usual, we have our jury consisting of Dr. Pradeep Rangappa, Dr. Ajit from Bangalore, and Dr. Kapil Dev Soni from Delhi. And as usual, I will be the chief moderator. So as we know that evidences are all bundles are always created to translate evidences into bedside. But how good are they when it comes to sepsis? We are going to hear a lot more on whether these bundles are really useful or they are first. But before that, I turn on to the mic to our first speaker from the member of the Treasury bench, Dr. Amrita Bhattacharya.
Good evening, everyone. Thank you, seniors, for inviting me to speak on this forum today. So I'll be sharing my slides. Just one moment.
Are you getting it, Amrita?
I am.
Oh, yes, good. Yes, you're good.
So I'll be speaking on the motion. In the real world, sepsis bundles are unrealistic and only satisfy tick box medicine. I have I have a small PPT for you. I just have 6 arguments, but 6 very strong arguments for you. My first point. So I've titled it, Prove It on Paper and Lose It at the Bedside. First of all, we're talking about sepsis bundles. However, so there are two parts of this. Sepsis bundle. If we don't know what sepsis is, or if we are regressing there, we can't really expect that our sepsis bundles are going to work. We have actually moved on to sepsis 3, where we are now saying that organ dysfunction is what we need to focus on. For decades, for years, luminaries around the globe have been trying to just do that, to ensure that we recognize sepsis early before it has moved on to organ dysfunction. The SOFA score has been encouraged by the Survival Sepsis campaign. The SOFA score, as we all know, is a research or prognostics tool. Not much evidence exists for its use in prognostication and for clinical care. Hence, that's my first argument for you, that if we don't really know how to define sepsis, what the hell are we talking about for sepsis bundles? And I'll give you my literature for that. So this is a retrospective analysis of 300 patients from the ED of 4 US hospitals. All of these patients had been stamped as sepsis and had been channeled into the survival sepsis bundles. When people actually went back and they asked 3 independent physicians to label this. This is how they did it. 34% of patients had no convincing evidence of bacterial infection in retrospect. Hence, my statement remains that if we force immediate treatment for a condition with this much of diagnostic uncertainty, 34% means 1 in 3 patients. 1 in 3% is misdiagnosed. Do we really not risk overtreatment? And how can this bundle be hence standardized? My second argument for you, if you can't agree on the starting gun, then you should stop timing the race. We've made 1 hour bundles, we have made 3 hour bundles, we have made 6 hour bundles. If we don't really know how to identify time zero, if we don't have a parameter, then how can we say whether or not a person is compliant, a physician is compliant? What is time zero? Once more, a study by Chanuri, he just, very simple study, 80 sepsis patients, 3 abstractors, 3 hospitals, and look at this. Only 36% were in agreement about the exact concordance. 1 hour, only 59%. And there was a 3 hour concordance about the time zero in 68%. So all this on the x-axis is time zero concordance. Only 36% had exact concordance. And even if you took a 1 hour margin, it was just 59%. So I don't know what time zero is. Only 1/3 of physicians agree that this on the same time zero. And then I am setting bundles for 1 hour, for 3 hour and 6 hour. Does this really mean anything? My third point, women. So this is a large audit, large literature study, which shows that association between implementation of severe sepsis bundles and performance measures. What did they show? They showed increased use in lactates and fluids. Mortality remained unchanged. And look at this. So lots of charts on this page, but what I want to draw your attention to is, look at the lactate measurement, how it has increased. Look at antibacterials, how it's increased. All of these curves are heading upwards. And then look at this. Look at in-hospital death or discharge and in-hospital death. No change. So we have invested money. We have invested antimicrobial precious resources without making a dent. My opponents will, of course, give you different literature, and I have an argument for them too. This is what my opponents are going to show to you. The study by Levi et al., by Prescott et al., where they show how the observed mortality changes after the surviving sepsis bundle is implemented. And I will show you something different. You see, in this year when this study was conducted, just look at this. The Q2 had 2000 and the Q2 of 2014 had 8,664 cases reported. And then this bundles was made mandatory to report this compliance. And here we are, 11,170 cases reported, 30% increase. Is it at all believable that over 3 months, there has been a 30% increase in the number of sepsis? No, it's not. This is over-reporting. This is increasing the denominator so that the ratio decreases. And look at this. Once you risk-adjusted these patients, once you risk-adjusted, the mortality curve actually flattened. What seemed like this has now become this. And this mortality prediction model had an area of under the curve of 0.77. Who knows? If we can get a better risk adjustment model, we can even flatten the curve more. Just a conjecture, but I think it's a logical conjecture. And this is what I was talking about, ascertainment bias. Look at this. Just as you have a decrease in reported mortality, you have an increase in the number of cases. So if your denominator increases, especially with non-severe cases, of course your mortality is going to decrease. It's simple maths. Number 4, of course, beat the clock and blast the flora. Mandated speed fosters indiscriminate antibiotics. I've shown you the evidence for that. And this is what the IDSA has come up with multiple papers which show that there has been a lot of overuse of antibiotics by your 1 hour and 3 hour bundles. My 5th point for you is to differentiate between septic shock and sepsis. They are not the same. This is how it started. The famous study by Kumar et al., which said that with every hour delay, there was an 8% decrease in survival. However, almost 50 to 60% of this population had septic shock. The same thing when we saw about the bundle compliance after the SEP 1 mandate, most of this mortality benefit from the bundles was actually driven by the antimicrobials. And what they showed is an each hour delay in bundle completion. That is antibiotic administration driven by that. There was a 4% increase in the odds of death. Once more, what was the number of shock patients? Look at this. For the New York State, when they further subdivided patients in shock and patients not in shock, the patients in shock had a far higher adjusted odds ratio of death than patients not on vasopressor. Once again, 40% of patients in this cohort had shock, and hence this 4% was driven by them. Separate studies, Northern California, randomized control trials, the fantasy trial, everything. Once the shock cohort decreases, this mortality benefit or this benefit from giving antibiotics early, that seems to disappear. And of course, the criticized, the 30 ml per kg intervention that we've all talked about. We've all talked about how 30 ml per kg cannot be a magic number. It has to be titrated, and I'm not going to add to that. But I am going to tell you this. Just look at this. Even after, if after you made a time compulsion for the bundles, just look at this. This is not about 30 ml per kg or 10 ml per kg. This is how long they took to give the 30 ml per kg and how the mortality curve. Look at this. Have you seen anything flatter? Nothing. And hence, I do not stand alone. I have people like Paul Marek. I have the SSC, I have the ACEP statement. I have people like Josh Farkas, everyone who stand with me and say that these are more of tick box exercise rather than an exercise in adequate patient treatment. That's what I want to put forward to this jury today. Thank you.
Thank you, Amrita. Amrita has been able to stand on the futility of following the bundles, and I think she had adequate evidences in her favor. And definitely, we are waiting to hear the opposing views from our members from the opposition bench. Dr. Kalavati Moses, can you stop sharing the screen, Amrita?
Of course, sir. Just a sec. Yeah.
Yes, Dr. Kalavati Moses, member from the opposition bench, is going to defend the sepsis bundles.
Yeah, thank you, moderator and the jury and the opposition members. Thank you for your presentation. As of now, the incidence of sepsis globally is 50 million. And of this, the mortality is about 11 million, which translates to about 1 in 5 who dies of sepsis, which is a huge number. We saw a statistic where a seemingly unnecessary antibiotic was given to 1 in 3. But compare the mortality risk, and coming to pediatrics, it is about at least 40% mortality is there in pediatrics, which is completely unacceptable. And since Rivers et al. Had released the EGDT, we have made a difference in leaps and bounds, and still the problem exists. And we are continuing to evolve and fine-tune our approach to sepsis. making it more and more sensitive in diagnosing sepsis. Early recognition is key and early intervention. And as we all know, sepsis, the management of sepsis is not any single therapeutic measure. Coming to diagnostics as well as coming to interventions and therapeutics, it is not a single measure. And that is the reason the concept of bundle has evolved, where no arm of intervention is neglected or overseen or not addressed. And that is where the multiple studies have shown through, and these are all time tested studies, which have been robust and classic landmark trials. Even after Rivers et al. Had released, multiple studies had come where the bundle approach has shown to have a mortality benefit. And it is not new to the jury that it has now come to the point where the early blood cultures and early antibiotics and early resuscitation are the foundational steps in the bundle approach to sepsis. Leave out any arm, again, the studies have shown that the patient, of course, the opposition member also said about fluids and whether 30 cc is the magic number or not. But then we have seen in various studies like the Clovers trial or the classic trial, where they have already given the basic fluid, a minimum of fluid, and then reassess the patient for any further need. And coming to antibiotics, about 34% seemingly had received unnecessary antibiotics. But then again, any medical decision, clinical decision is about the risk benefit. And when we are faced with a huge mortality possibility, it outweighs the small risk of an unnecessary, supposedly unnecessary antibiotic till it is proven otherwise. Because the bundle approach also shows that if there is any doubt, then you may investigate the patient and then make sure that the patient does not need any further antibiotic. But still, the guidelines say that you go for an antibiotic when there is a suspicion of sepsis, which puts our stand regarding an early antibiotic, a broad spectrum antibiotic, depending on the local antibiogram and the local prevalence of the microbes. Um, uh, within the first hour, if the patient is in shock or if there is a strong suspicion of the sepsis. So that is where we are. And then there were some statistics shown regarding the mortality and how flat the curve is. But then again, there have been robust studies regarding the increase in mortality with every delay in Evans up to Evans et al., right from Seymour to Evans et al., have shown that the time to antibiotic matters. We have fine-tuned it so much that now, as much as in stroke um, or MI or trauma, where there is a time-sensitive intervention which is advocated, now it is door to antibiotic is the new evolution, which shows that we are still in need of the bundle approach on multiple fronts. So here I stop, and if Dr. Supradeep also has got any argument.
Thank you, Dr. Kalavati. Kalavati has tried to establish her views strongly. So let's see. I don't know what the situation is, but now the time is for our senior Solicitor General, Dr. Prakash Shastri, for the motion. Yes, sir.
Right. I must commend Amrita. She managed to use her good vocabulary, and she did present a wonderful case, and it was all staggered in such a way that one evolved into the other. And obviously, I'm supposed to say in her favor. And so I'll have with due apologies to Kalavati. I have to tell that, okay, she made a very strong case for early antibiotics. Yes, we have got good evidence for early antibiotics, and that has shown to reduce mortality right from 2005 or 20 years back. We have that evidence for that. My question to her is very simple. She says the cost benefit analysis. She says that, I mean, Antibiotics are very safe compounds. You got a license to use antibiotics. But she deliberately, I believe, shied away from accepting that, okay, 48 hours, you are licensed to use anything that you like. What about after 48 hours? After 48 hours, when the cultures do come in, then the same bundles and the same literature and the same evidence says that you have to de-escalate the antibiotic. Now, actually, at the bedside, all the big panelists are there. Ask them, each one of them, how many do de-escalation. All they talk about procalcitonin based de-escalation and all when they are in the conference. But when it comes to actual practice, I don't think they do de-escalation. And cost benefit. The cost that you're paying is the kind of resistance that we are seeing in the entire country today. Meropenem has got out of the window. I'm getting a lot of colistin resistance in my patients. I'm not left with any antibiotic. We are not talking about collateral damage. We are talking about the magnitude of resistance that India has become a capital of, something like diabetes. And that is the price that we have paid. And was it justified to pay that price? There you can understand your cost benefit analysis. And I agree with Amrita that the definition that I have grown up is that, okay, this is a presumed sepsis. So in presumed sepsis, you are given the license to implement the bundles. Now, what happened again? If it turns out to be a not sepsis, then nobody wants to upset the apple cart. They just carry on until it is 5 days and 6 days. Then they think, okay, we did not cover antifungals, so let us add antifungals. So one more antibiotic is added. So third thing is that quite a lot of time in Indian ICUs, it is difficult to get the patient into the ICU as soon as a red herring is exposed that the patient is sick. It could be a sepsis, it could be any other patient. It takes time. So you need to have a good resource kind of a setting in which you, if you are trying to implement the bundles, and that is a mandate that has been given to you by the management, then actually speaking, you have to implement the bundle right in the intensive and right in the casualty or emergency room itself. And we know emergency medicine, Kalavati would pardon me. Maybe in South India, there is some established emergency medicine department. In North India, there are still a lot of places where emergency medicine department is manned by just medical officers who don't have a postgraduate degree. And there, if you expect them that they will follow and implement, they will recognize number one, and then implement at least that 1 hour bundle before the patient gets shifted to the ICU. You're asking for the moon. So they actually the first hour bundle starts when the patient comes to the intensive care unit. I agree with that. But by that time, it could be 3 hours, it could be 6 hours, depending upon the availability of bed in the ICU. So again, on the bedside, sometimes, more often than not, I would say, it is difficult to implement the bundles, but we do follow them in principle. To that extent, I have to give her the credit. Yes, they laid down a roadmap as to what we are supposed to do in case we are dealing with a patient who has either known sepsis or presumed sepsis. But yes, if it is a presumed sepsis, then we tend to overdo things and if and sometimes expose the patient to unnecessary interventions, which he could have otherwise escaped. But then, as Kalavati just now mentioned, cost benefit ratio is benefit is so far high that I don't bother about the cost. So that is the argument that she gave. So I rest my case here. Please go ahead.
Thank you, Prakash sir. So Prakash sir has reinforced the belief in everyone's mind now that sepsis bundles are are not useful. But now we have our final speaker, and on who is known to be a major influencer, because who's after he speaks, a lot of people change their views. They get brainwashed. So I think now it is time to hear to Dr. Supradeep Ghosh, and let's see how Dr. Supradeep Ghosh defends the bundles in this debate. Dr. Ghosh, please.
Thank you. So let's start with the definition of sepsis. The first thing which Amrita pointed out, I congratulate Amrita and Kalavati, both of them. They have done well. She started with the definition of sepsis. So before I come to the definition of sepsis, let us try to understand how many of us do not believe in sepsis. We all believe in the existence of sepsis, and it is there available in ICD also. The definition of sepsis is changing, it is evolving. We're starting from the Roserbone to the latest 2016 sepsis 3 definition. We know the definition is not perfect. We know it very well. But this is the definition which has been adopted in 2016, considering several things into consideration. So many things were considered, and they found, even the authors, both Marvin Singer and his co-author, both of them agreed that this is not the best thing. The 40% mortality, septic shock causes more than 40% mortality, and sepsis causes more than 10% mortality, something around 16-17% mortality with the current definition, which is being proposed in 2016. So we know it. But we also know that sepsis is dreaded. It's devastating. 1 in 5 people across the globe die from sepsis and septic shock. 1 in 5 people. And when it comes, this involves the Western countries. When it comes to sub-Saharan countries, when it comes to Southeast Asia, when it comes to not the corporate ICUs of the big hospitals, the big ones from the cities of India, go to the villages, sepsis is the biggest killer. So until and unless we have some definition, at least, kuch to ho, some definition. So with this definition, we have to move on. And with time, as the time progresses, our definition will definitely evolve. And Surviving Sepsis campaign is adapting to the definition. So this is saying that this definition doesn't, and as we evolve, we'll definitely go back to the something. But we have to give something to our initial primary care provider. So I don't think we can have any other better thing for this. Now coming to, and second thing, we know that sepsis is a very complex process, extremely complex. It involves a lot of things. And primarily, why there is a sepsis? Whenever you treat sepsis, the first thing is to treat the infection. And to treat the infection, you have 2 components. One is the antibiotics. Now, antibiotics, while using antibiotics, Surviving Sepsis campaign doesn't talk about the antibiotics. Surviving Sepsis campaign just talks about that this should be given as early as possible. And we all know it. There is no doubt about it. We have to give antibiotic as early as possible. But Surviving Sepsis campaign doesn't tell us that you have to give this particular antibiotic. So while applying, so antibiotic stewardship is a different concept altogether. While prescribing antibiotics, the particular doctor, whoever is there, he or she has to apply his or her common sense, depending upon which source you are treating, which source, what are the possible organisms, is there any evidence of resistance, what are the organ dysfunction is there, whether there will be penetration of the drug to the particular organ, how much is the cost, and what are the possible adverse consequences. Based on this, you decide your antibiotics. Second thing, even if we give 2, 3, 4 antibiotics, there is always a scope for de-escalation. Saying that, okay, you will not de-escalate or you will not stop antibiotic based upon whatever available evidence is, that should not tell us that we should not give antibiotics. You need to give antibiotics. But antimicrobial stewardship, we can have a separate discussion on this. But saying that antibiotics should not be given, should not be started, or at least thought about antibiotics within 1 hour, just because we'll cause more harm to the patient. We are not causing harm to the patient. We are actually trying to save the patient. And we are causing harm to the patient, but by not following antibiotic stewardship guidelines, not by following the Surviving Sepsis guideline. Surviving Sepsis campaign guideline just say within 1 hour you should give antibiotic, and there is no doubt about it. Coming to other components, let's see now coming to the bundles and checklist. It is whenever you go for a quality improvement initiative, the best way to initiate a quality improvement initiative is to give them a bundle approach. We know it from Peter Bonobos, and apply a checklist. And we know it from the 2009 surgical safety checklist study by Atul Gawande and his team. We all know that checklist is good, that whether we have given fluid, whether you have checked the lactate, whether we have done the blood culture, is done. So we have to follow a bundled approach. And whenever we follow a bundled approach, we need to see available evidence. So let's see. And bundled approach, whenever we follow bundled approach, they say that 5 to 7 things to be kept. So surviving sepsis campaign bole, let's see at least this much 4 or 5 or 6 things should be done as early as possible. Now this is as early as possible. And surviving sepsis campaign guideline has clearly said they do not expect all the 6 components to be finished within 1 hour. They just expect that should be started within 1 hour. Coming to lactate, who doesn't believe that lactate should not be checked whenever you are going for a patient, critically ill patient, any critically ill patient, wherever it is available. If it is not available, fine, then we can't do anything. Then we go for all these cold peripheries or capillary refill time and other things. Wherever there is availability of lactate, we check the lactate, because we know if the lactate is elevated, we need to look for whether it is a patient is in shock or the lactate is elevated because of some other reason. So lactate is good. Secondly, if it is a septic shock, we follow the lactate. We serially follow the lactate. It's a well accepted terminology. So lactate, there is no question about the evidence behind prescribing lactate. I mean checking the lactate. Second thing, surviving sepsis guideline says, take the blood culture before giving the antibiotics. Is there any doubt about it? We need to go for a blood culture, 2 sets of blood culture, because this is a part of the antibiotic stewardship, and surviving sepsis campaign guideline is encouraging that. Where is the doubt? If we do not take the blood culture, how will you de-escalate? If you do not take a blood culture, how will you know that what is the trend of your antimicrobial resistance? And how do you know whether you're dealing with a drug-resistant pathogen or not? So, and I believe in future, we'll be having more and more implementation of other pathologies like PCR-based techniques and so many other things. 10 years back, we were not aware about all these things, or maybe 20 years back, but maybe 10 years down the lane, we'll be seeing more advanced technologies. But as of now, we have the technological blood culture. Wherever there is availability of the blood culture, we know many of the places in India, we do not have blood culture. Where do? We forget it. But at least wherever it is available, we must go for blood culture. Third one is the antibiotic. I've already discussed about that. I don't think there is any doubt. A young lady, a 24-year-old girl, presenting to us with a pneumonia and hypoxemic respiratory failure, not in sepsis. Who is not going to give antibiotics to this girl? Everybody is going to give antibiotics. A young boy presenting with a necrotizing fasciitis, will you wait for the culture? Will you wait for the boy to develop septic shock? We will give antibiotics to this boy. So that's important. We all practice that. I'm not telling somebody is coming with a running nose and a pharyngitis, you give antibiotic. No. Surviving sepsis campaign doesn't say this. Surviving sepsis campaign says whenever there is evidence of sepsis or septic shock. What is sepsis? A guy or a girl presenting with evidence of or strong possibility of infection with evidence of organ dysfunction. As somebody who has got organ failure with a SOFA score of 3, wouldn't you give antibiotic to this patient? We will give antibiotic to this patient. There is no doubt about it. Coming to the fluid, 30 ml per kg body weight. Now let's see our evidence is evolving. Our evidence regarding fluid therapy is evolving. 30 ml per kg body weight. You see the previous guideline of surviving sepsis campaign, which was published somewhere in 2016, I believe, 2016 or 17. It was published that actually recommended 30 ml per kg body weight. But in the latest guideline published in 2021 or 22, that says, we suggest to give up to 30 ml per kg body weight. And they do not say that you have to give all 30 ml per kg body weight within 1 hour. They just say you give fluids starting with 1 hour, and they also say you need to look for fluid responsiveness and fluid tolerance. And why this 30 ml per kg body weight? 30 ml per kg body weight is based upon a retrospective analysis. And of course, if you see, not the Emmanuel Rivers, the great man, these latest 3 trials, ARISE, PROMISE, and PROCESS, in all the 3 trials, and the combination of these 3 trials, in an average, patients receive 30 ml per kg body weight. So they suggest that you should go for up to 30 ml per kg body weight. But of course, at the same time, they have said that you should look for fluid responsiveness, fluid tolerance, and other things. So this 30 ml per kg body weight is not sacrosanct. But give fluid. Is there any doubt regarding not giving fluid? Who doesn't give fluid to patient with septic shock? Everybody gives fluid to patients with septic shock. All panelists will agree with me. Who is not giving fluid to septic shock? Even with patient comes with a 30% ejection fraction with a pneumonia and septic shock, we give fluid. May not be 30 ml per kg body weight, but at least start with some 250 ml. No doubt about it. Coming to vasopressor, is there any doubt? A patient present, again, vasopressor, things are evolving. If you look for the old surviving sepsis campaign guideline, 2004 guideline, vasopressors were prescribed only after the fluid resuscitation is over. But look at the guideline. Guideline is evolving, but as we are going into the evidence, if we are gaining more evidence, we are maybe endometrial shock 2 trial is going to be published by the next year. Hopefully, we'll be getting a more robust data about implementation of vasopressor, when to start vasopressor. Maybe when the wide pulse pressure is very wide, when there is very low diastolic blood pressure, we'll start starting the vasopressor early. But even now, surviving sepsis campaign guide, as early as possible. Then they don't say that complete the 30 ml per kg, then start the vasopressors. So all the 5 components or 6 components of surviving sepsis campaign guideline, the 1 hour or 6 hour, 3 hour, whatever by the bundle, they are all evidence-based. Now coming to the studies, I think the SAMUD study is pretty comprehensive and pretty, but Amrita has also shown that study. And that study has shown, okay, individual component. We all know, bundle, individual component may not be very great. Individual component. In the SAMUD study, they have not seen the all individual component. They have seen if you implement the surviving sepsis campaign guideline, this bundle approach, between 3 hours and 12 hours. Somebody who has completed within 3 hours and somebody who has completed beyond 3 hours, the chance of survival improves greatly if you can complete this bundle approach within 3 hours. But when it comes to antibiotics, it has shown a statistically significant benefit if it is given within 3 hours. Other things has not shown. Overall bundle, improvement mortality benefit. Overall antibiotic usage within 3 hours, mortality benefit. Fluid has not shown mortality benefit, but there was a trend. At least there is no harm. But if you go for fluid, if you go further to your study, those patients who have received this 30 ml per kg body weight beyond 12 hours, those who have completed within 12 hours, they have a better mortality benefit compared to those who have finished after 12 hours. So again, giving fluid early is good. It's just like Emmanuel Rivers. If you see Emmanuel Rivers study, after 72 hours, both groups received similar 24 liters of fluid. See, we have reduced from 24 liters to 3 liters. So 24 liters, both the groups, but the groups in the intervention group, they received the things early. This same thing has been shown in the SAMUD study. In the SAMUD study, if the patients receive fluid within 12 hours, they complete the 30 ml per kg within 12 hours, they do well compared to those who have completed it beyond 12 hours. So I think we have a complex situation. We need some quality improvement initiative. Whatever available data we have, based upon this data, we have to go ahead with something. We have to give some guidance to our colleagues. Everybody is not like Dr. Prakash Shastri or Dr. Ajit, or everybody is not guided by Dr. Shastri or Dr. Ajit or Anirban. And so we need our young chaps to give something, start with something. By that time, Dr. Shastri will drive down from Gurgaon to Gangaram Hospital and guide you further. So I think I'm strongly, and regarding checklist, I strongly believe in checklist. Kya lactate liya? Tick. Kya blood culture liya? Tick. Kya antibiotic diya? Tick. Kya fluid start kiya? Ringa lactate start kiya? Tick. Kya vasopressor start kiya? Tick. Tick completed. Your job is done. A young boy or young girl who is sitting in the casualty or in the emergency or in the ICU, their job is done. By the time Ajit will come and do the rest of the things, I think I strongly believe Surviving Sepsis campaign guideline is doing very well.
So thank you, Dr. Ghosh, for again defending the bundle approach and trying to prove that bundles are always very useful. But I think after what you have said, and you have left out throw a lot of arrows, I think I should give a chance of rebuttal to the members of the Treasury bench. Dr. Shastri or Dr. Amrita, either of you or both of you, you can quick rebuttal after from what you have heard.
Amrita first.
Yes,
Yes,
Amrita.
So Shubhradeep sir, I completely agree with you that bundles are good. But not all bundles work, do they? But the bundle is as strong as its components. And I'll cite for you the cap bundle. We had, I believe, it was around 2012, I might get the date wrong, but cap, they had good retrospective data, and hence prospectively they wanted to give antibiotics within 4 hours. Fell flat mostly because cap is a very protean entity, lots of infarcts, organizing pneumonias, etc., confusing the picture, and hence lots of misdiagnosis. Hence sepsis is exactly like that. It doesn't just bundles are good is a very broad statement in my opinion, and we have shown in literature again and again not all bundles work. Sir, you spoke that for sepsis the definition कुछ तो चाहिए, but कुछ तो चाहिए cannot be good enough for कुछ भी चलेगा. We need something. कुछ तो चाहिए, of course, but कुछ अच्छा चाहिए, sir. That's my response. And sir, we're not asking not to give antibiotics when infection is obvious, when a person comes with necrotizing fasciitis. What we are asking is that when infection is not obvious, wait, pause, reflect, and then give. So that would be my take, sir. And of course, there is the infrastructure issue, which also drives a big debate in our country, because you would agree with me that surviving sepsis, or at least the SEP1 has said that for complying with a bundle, you have to fulfill all of the components, not one, but all. And hence, complying with all of the components might not be very, very feasible in our country, at least in the rural setting. And
Thank you,
lastly, I would just
Amrita.
sir,
Yeah,
one more thing. Bundle compliance. I know, sir, you have stated that bundle compliance decreases mortality. It is driven by antibiotics, of course, but then my point is also that a person where a setup where a bundle is being completed in 3 hours, as compared to a setup where a bundle is being completed in 12 hours, doesn't it simply reflect that the 3-hour person is doing a better job, that institute? Doesn't it just simply reflect that the global care is better? And hence, the mortality is obviously lower there. That is my take, sir.
thank you. Okay, Dr. Shastri, quick
I
rebuttal.
must congratulate Supradeep that he made a wonderful statement that sounds very nice and in academic circles, and nobody has any disagreement with whatever he said. The question is not the bundles are right or wrong. The question is their implementation. And that is what I summed up in just one line by saying that yes, the bundles are a wonderful roadmap for you to have. The question is the inability on our part to actually stick to those bundles and actually implement them. And what are the constraints that prevents us from implementing them? And yes, individual variation will always be there. And that is why, as of now, just ticking the boxes looks very nice on paper, sounds very nice when you're hearing it in a lecture theater or in a conference. But when it comes to the ground reality, unfortunately, things are not happening the way you would like them to. Yes, but that doesn't mean that we don't have to have a God. The God is there for us to show us the light, that this is the path to be followed. But that doesn't mean by following that path, you will actually reach the God. You will actually become the God. But yes, you need some kind of a roadmap for you to follow. Otherwise, it becomes chaotic. And then, obviously, when it becomes chaotic, you can't do any research whatsoever. So, thank you, Supradeep, for that eloquent statement. And I'll accept that
sir.
roadmap is, as a roadmap, it is a decent thing.
Thank you, sir. We
Can
are
I
going
come
to
in?
listen. We are going to listen it from our. Yeah. Okay. Rebuttal quickly. goes down. Yes.
Now, coming to the problem is when we were following the SIRS criteria. When we are following the SIRS criteria, there were a lot of this Australian study which was there and many other studies. They have clearly shown that when we are following the SIRS, the sepsis 1 or even the sepsis 2 definition, so we were over-diagnosing sepsis, but we have evolved over a period of time. We have shown that, like huge credit goes to Surviving Sepsis guideline and the Surviving Sepsis campaign as such, that they have actually propagated the importance of sepsis care. Why? How important it is to take care of the septic patients and sepsis patients as early as possible. The most important thing is the early. So this is the sepsis. The whole credit goes to Surviving Sepsis guideline and SSC.
Just one sentence.
Sir, let me complete the things.
Yeah.
And the thing. When there is SIRS, we had a lot of overdiagnosis. Now, Amrita was mentioning about the CAP guideline. Now, let us talk about the SSC context only. Let's take about a CAP guideline. Now, a CAP will become a sepsis only when the patient has a PF ratio of less than 300, I think, less than 300. So you have a guy with X-ray showing evidence of pneumonia with a PF ratio of less than 300. Is there any doubt regarding giving antibiotics? Any guideline, even IDSA CAP guideline, which was published, I believe, in 2019, that also suggests the same thing. That suggests only thing is that antibiotic choice will be different. Here in this case, you can give a beta-lactam or a microlide. When it comes to severe CAP, the PF ratio goes down, patients require mechanical ventilation or patients require vasopressor support, you add both. So, but giving antibiotics, so which antibiotic to be given, that depends upon the severity of the illness. Why it depends upon the severity of the illness? Because if the patient, whether the patient will tolerate, whether if we make a mistake, whether it will be justifiable for the patient or for the particular patient based on this. But when it is as per the current definition, we call a CAP a sepsis only if the SOFA score is 3 or above, 3 and 4. That means 300, I don't know, maybe some 200 or 300, whatever that PF ratio, severe. And when the patient is in mechanical ventilation, you need so that CAP guideline which Amrita was talking about is that's Compass guideline. I don't remember even this guideline. I agree that a guideline will not be, but when it comes to SSC guideline is specifically mentioning about this. Rahi baat, we are all evolving. We have seen sepsis, how we have no doubt that sepsis is something and sepsis is a killer. And we are evolving. In due course of time, we'll see more changes. But as of now, whatever is available. Now, why I'm telling this, I believe few months ago, I read a study in Blue Journal where they were talking about the Europe is a developed continent, not the Asian continent. And even in European countries, the sepsis care is variable, resulting in, this is a Blue Journal, I don't know, you need to read, I don't remember in detail, but I remember this much, that there is a variable sepsis care even in continent like Europe, leading to different mortality, different rates of mortality. So that means we need some sort of standard of care, some sort of things, and fine-tuning can be done after some time. We can de-escalate, we can stop early. How many of us actually stop? I stop early. I can very proudly say.
Thank you,
Procalcitonin and this thing. So we need to
one-liner.
Yes, Dr. Shastri, please. Quickly,
we talked about developed nations. If you think that we are evolving as far as learning more about how to manage sepsis, then I'm afraid from 1994 to 2025, we haven't done a very great job. We have brought down the mortality from, let us say, 30% in developed nation to 20%. And I firmly believe that this decrease in mortality is because of better nursing care rather than so-called preachers like Dr. Supradeep and including Dr. Shastri. I stop there.
That's nice one. So now it is time to listen to the jury. I will start with Dr. Kapil. Yes, Dr. Kapil,
So, hi.
You have heard both the members of the Treasury and the
Yes,
opposition bench.
yes.
So
First of all, I
now
must,
the choice is yours.
yeah. First of all, I must tell Dr. Supradeep, water evolution. I used to hear him. He was leading a lot of crusade against the bundles many years back, and now he is proponent for the bundles with such a.
भाई डिबेट करना है डिबेट डिबेट करना है भाई
So I must tell you, right. So what
No,
a
no,
great arguments. I must tell both the teams. They proposed a really good arguments. But as a jury member, I have to make decisions. So first of all, if we talk about our own country, and as highlighted by Dr. Supradeep and his team as well, that there is a lot of variability. You will not find Dr. Supradeep and Dr. Dr. Others specialists, yes, other specialists in every nook corner of the country. The country is quite a vast, and there's a lot of variability. So how, if we are rolling out a guideline, we have to think population as a large. How can we provide good to a greatest number of patients? In that case, bundle is one of the safest way to improve the caliber of the people who are treating patients in remote parts, in a austere environments. So bundle actually help in improving the quality of the care which has been delivered. Uh, but then there are some certain limitations of bundles as well. They would be effective to a certain extent. Beyond that, they are not going to be effective. So, but given the present condition, we are far away reaching to that stage. For our country, bundles are still a must as a largely as a policy decisions, and that would help in improving the care which we provide to the patients.
Dr. Pradeep Rangappa, please.
Yeah. Thank you, Anirban. I think at the outset, I wish to congratulate both teams. They excellently elucidated and edified us, and Supradeep, Prakash, and all so eloquently, Kalavati and Amrita. So well done, all of you. So I think it's left little to us to argue on either side. But I've always been against the bundles. But let me just try to put it and encapsulate in a better way. So I sincerely believe, I think all the esteemed panelists, we don't need bundles for any of the panelists. I'm sure each one of you would agree. Even Supradeep will agree he doesn't need a bundle. So these bundles or these surviving guidelines, we all agree that it is for a general sort of a practitioners, maybe a surgeon, maybe a physician treating in the wards to identify sepsis. The whole purpose of this is to identify and initiate. If you look at the sepsis chain of survival, which is now the new sort of a buzz that is making, the chain of survival typically re-emphasizes and reinforces that we need to identify sepsis early. There is a continuum of this care that we are talking about. When we say continuum, it is starting antibiotics early and starting fluids early so that there is no delay when they come to intensivists. For all the extreme panelists who are here, who are all proficient intensivists, I'm sure all of you can put your hand on your heart. You don't need a bundle because we are here to argue the deficiencies in the bundle. When you make it more granular, I can find thousands of deficiencies in each and every sort of a suggestion that comes out of this bundle, which I'm sure all of you are well aware. So just to highlight 2 points, just to counter Supradeep, although he's so excellently talked about the fluids, and he's a fluid man, but I want to argue with him. If you look into the bundles which evolved from the rivers, they use 10 liters, 168 ml per kg as the fluids. And then that was in 2001. And then in 2014 to 15, we got the trio trials, which is process, arise, and promise trials, where they cut down to 100 to 130 ml per kg of fluids. And then the RIFT trial in 2019 came with 47.1 ml. And then the refresh trial, classic trial, and the Clovers trial, which is the latest, 2023, used only 1,267 ml versus 3,400 ml. So which means we have evolved as an expert. I'm talking about an expert group trying to say, yes, there are deficiencies in the bundle and we can't agree upon such a massive amount of fluid. So that's about the fluids for Supradeep Da, who's a fluid man. I'm sure he'll agree with each and every point I'm telling. For experts, we don't need a bundle. And antibiotics, even this is to counter Supradeep. You look into the meta-analysis by Sterling. Although you have spoken about individual trials, the Sterling et al. Meta-analysis, 11 studies, 16,178 patients. They have compared antibiotics more than 1 hour versus less than 1 hour versus more than 3 hours, and they did not find mortality difference. Okay, will not believe meta-analysis, forget about it. look at all the recent ProCal trials, like ProRata trial, Progress trial that came from the Greece just in 2023. All these trials, what are they telling you? That you give antibiotics in patients who don't need based on ProCal indiscriminately. In fact, the mortality was high where antibiotics were indiscriminately given who did not need that. So which means to say we need to exercise caution in overzealous usage of these things. So that's all is my submission. So there are deficiencies. So bundles are for general doctors or non-intensive care specialists. Let me put it this way. For all the expert specialists who are present in this panelist, all of us can put our hands on our heart. We can criticize each and every suggestion that comes out of the party. That's about it. Thank you very much.
Last jury, Dr. Ajit AK.
Yeah, so I think I would like to congratulate both the teams, for the excellent arguments. So from my perspective, means the sepsis is a major killer of mankind. Actually, sepsis is multi-organ dysfunction, and septic shock is a major killer of mankind. To the best of my knowledge, means the only killer which can compete neck to neck within a sepsis, in killing humans is acute myocardial infarction. I know there are a lot of developments are actually happening there. Obviously, you can talk about breast cancer, I believe, if I'm not mistaken. And even AIDS, these are the major killers I know. But sepsis is a major killer that you cannot do that. And only competing will be with acute myocardial infarction. That's this one. So in that major killer is suspected and coming to the emergency. So naturally, because there will be a lot of, physician concern, physician anxiety is going to be there. And this issue will be more when you are unable to identify the source of sepsis. Whenever you suspect sepsis, when you are unable to identify the source of sepsis, then only the major issue will arise. So unless you have the issue is that in this situation, the people will tend to err more towards treating as sepsis. What I mean to say is that which will result in an antibiotic abuse, misuse, slaughter. What is going to happen? That is what I can gather from the discussion. So the thing is, the reality is that unless you have a point of care test, rapid diagnostic test at the bedside to identify an infectious condition from a non-infectious condition. And if at all there's an infectious condition, you have some kind of a rapid, and even it's all evolving. Like Supradeep was telling, it's evolving. You can identify the antibody sensitivity also. Like the few tests are PCR and other based tests are all evolving. These things are readily available. These issues will, the physician anxiety will be there, and there will be always a tendency to err towards more over treating. I agree there's antibiotic abuse, misuse, slaughter will happen. That is one thing. One thing which is probably unpreventable at this point of time. Only thing at this point of time is that all the people who are treating sepsis has to be more cautious. We should not do that. Even the sepsis guidelines are telling the patient does not have septic shock. Even even if you suspect sepsis, you can wait up to around 3 hours before you try to find out, try to delineate anything can be any other non-infectious conditions you are dealing with or not. You can wait for some more time. That is there. The people has to have an increased awareness, about the judicious administration of antibiotics and other things. That's what I would like to say. And at the same time, regarding the sepsis bundle, obviously the first hour bundle is telling that you give around 30 mils per kilogram body weight, when the lactate is more than 4 millimoles. And I have a kind of I believe there is a conflict in the surveying sepsis guideline, which says that in a hypotension, you give the 30 mils per kilogram body weight over 3 hours, because 3 hours to me it's a long time, because, the septic shock by definition is that, you require vasopressors to maintain a mean arterial pressure more than 65, and the lactate is more than 2 millimoles. 2 millimoles, both the criteria has to be there. So when you say that you give the fluids, the optimal fluid, nobody knows, despite fluid resuscitation. You don't know the optimal fluid, but this optimal fluid, when you say you give it over 3 hours, I think there's a big blunder. Basically, that delays the the treatment or whatever the treatment of septic shock by more than 3 hours. I think that's a major lapse in the not in the bundle, that the survey sepsis guideline. That's what I believe. And otherwise, that's the only thing I need to say, because as long as unless we have a rapid diagnosis test, this issue will be there. But only thing at the moment we can do that, we have to be extremely cautious. Again, he said every point we should try to rule out a non-infectious conditions, and we have to be judicious as much as in prescribing antibiotics. That will be my take on that.
Thank you. Thank you, Ajit. We have heard all the debaters, we have heard all the jury. So, friends, this, if we look upon bundles, they can give us a framework, but they cannot give us a formula as of now. And therefore, we should follow them in principle. But if we just try to enforce them blindly, we may end up causing harm. So, with that note, we thank all our esteemed experts who joined us for the debate and all our jury members. And till we come back with more such electrifying debates in the future on the second and fourth Thursdays, from all of us in JIX Fight for Debate, it's from all of us. Shubharatri, Shabar Khayat, good night.
Good night.
Thank you, Anirban. Thank you all the
Thank you.
panelists. We had a
Thank you
great
all.
show. Thank you all.
Thank you.
Thank you.